Hello, welcome to the symposium entitled Megatron Stent, What's New?, sponsored by Boston Scientific Company. Well, we all know that the family of Synergy stents have been with us for maybe close to a decade. And so Megatron is the latest addition to this family of platinum chromium stent. So the objectives for these sessions are, one, to learn how to optimize PCI outcomes when treating complex lesions such as left main bifurcation. Number two, a systematic use of adjunctive devices and intravascular imaging to simplify a complex PCI. And number three, to learn how to use this new Megatron drug-eluting stents in complex left main PCI. So my name is Dr. Hui Chim Tan, and with me in the studio as expert discussants are Dr. Jack Tan and Dr. Hee-Hwa Ho. In this symposium, we have also international discussants in Dr. James Zhang Junjie from China and Dr. Teguh Santoso from Indonesia, which obviously made up a very impressive list of faculty lineup that we have this afternoon. These sessions will not have served its purpose of an educational event without you, the audience, participating in it. I'd like to welcome all of you who are logged on to type on your questions and comments onto the chat post, and we will try to answer all your queries as much as we can. And today, Dr. Muhammad Ali Rosli from Malaysia will be your chat master, actively engaging with you online. For selected questions of interest, Dr. Hee-Hwa Ho, my moderator here also for the sessions, will also raise it for discussions with our studio and remote experts. So I would now like to begin by sharing with you about this exciting new stent called the Megatron drug-eluting stent. So if you look at the Megatron stent and compare it with the current Synergy XT stents that we are using right now, mark in red are the common similarities between this new stent and the existing one. So it is a platinum chromium platform. It is still made out of biodegradable polymer that is going to degrade within 3 to 4 months. And it's still coated with the drugs of everolimus drugs. And the coating is still of the same tightness. It's about 4 microns in terms of diameter. And that's where the similarities will end. But we all know that from a long time that the platinum chromium stent probably has got the highest and best-in-class axial and radial strength. And we know that radial strength is really the force that the stent can withstand with regard to any sort of recoil that the vessel may impose on it. So looking at this particular chart here, it will tell you that the platinum chromium stent is at least 73% more radial strength than the cobalt alloy stents and far greater than some of the current second generation drug-eluting stent. And again, looking at this slide, you can now look clearly the difference between the Megatron stent on the left side and the Synergy XT stent on the right side. If you look at the first two segments, which is way on the extreme left corner of the Megatron slide here, you can see that there are actually 4 connectors in the first 2 segments versus 5 connectors in the existing Synergy XT. On top of that, if you look at the number of peaks in the segment, there are actually 12 peaks in the Synergy Megatron stent compared to just 10 peaks. And then the strut length is also shorter in the new Megatron stent compared to the existing XT stent. Also, if you look at the rest of the stent itself, there are 3 connectors linking all the different segments, whereas the Synergy XT stent has got only 2 connectors. Now, looking at the entire Megatron stent thickness, you find that it is obviously thicker than the existing Synergy 3 model. So even the largest of 4.0 Synergy XT is sort of thinner compared to the Synergy Megatron stent. What it all means is that it adds on to an added strength as far as this stent is concerned. What is also interesting here is that Megatron stent is really made for big vessels here. If you look at a 3.5 Megatron stent, it is potentially possible to expand it all the way to 6 millimeter. And right now, there's no other stents in the market that can actually go all the way up to a 6 millimeter without any risk of a stent architecture disruption. So Megatron stent is really a stent meant to provide a uniform lesion scaffolding. Again, you look at the picture here, 3.5 millimeter and stretch it to a 5 millimeter. The coverage continues to be very adequate and uniform, regardless of the size of the vessel. And also, we all know that platinum chromium is far more radio opaque compared to many of the other alloy stents. And so if you want to position it properly, you want to know exactly where your stent is located, you can actually see it very clearly, even with just normal fluoroscopy. So if I have to say that Synergy XT is a stent designed to heal with extra deliverability, then Megatron stent is a stent designed to heal with strength. So having heard all this, Jack, how do you think this stent is going to feature in your clinical practice? Do you think it's got a specific purpose? Is purpose-built for certain lesions and so forth?
Thanks, Hui Chim. That was a very succinct presentation as usual. Finally, a company has listened to us. What I've been asking for throughout is a purpose-built stent for the osteo location, for the left main indication. And we do know that this stent looks like it's a perfect stent in my practice for the left main indication because of the extremely good opacity on fluoroscopy even, the fact that the proximal connectors and peaks are more, and ensures that there's a higher axial strength on top of the increased thickness for the radial strength. We know that left main often are calcified, fibrotic, particularly at the body and ostium or the left main LED ostiums. So I think this type of platform really is, in my mind, almost near perfect in terms of what it delivers on paper, and my initial experience with Megatron stent has proven it to be true. So I really like this stent for the left main location, Hui Chin.
So as I understand, the Megatron stent is currently only available in Singapore, at least in this part of the world, but it's also available in Europe. So Hee-Hwa, what is your take on the Megatron stents? Have you had any experience with it thus far?
So far, I have not had any experience with Megatron, but I think from what I agree with what Jack said, that it is purpose-built for large proximal vessels. I think a lot of times when we do stenting for left main to LAD, I think the LAD size is very often 3.5 or 4.0. So to have a stent that you can upsize from 3.5 to 5.5 or 6.0 without fear of stent fracture, I think that is a very important feature that the Synergy Megatron brings into our practice.
Very nice. I think there's no better way to see how this stent can be used clinically than looking at a case that probably illustrates the use of it best. So can we go to the case from NUH as we go about further discussion of the stent?
Hi, welcome to National University Heart Center, Singapore. And we're happy to be transmitting a case here of much educational value. My name is Tan Hui Chim, and with me is Rapunzel Tan and staff nurse Wilma and radiographer Teddy. So our patient is a 73-year-old gentleman with risk factors of insulin requiring diabetes and hypertension. Now he has chronic renal impairment with eGFR of 29 mL per minute. Now he has a past history of angioplasty to his diagonal artery, which has since closed off. Now he presented in July this year, which was about a month ago, with NSTEMI. And this was complicated by left ventricular failure, following which he was stabilized and had a coronary angiogram done. And this is the angiography that is being shown to you right now. His right coronary artery only shows minor disease. So the main culprit lesions for his NSTEMI appears to be coming from the left side. This angiogram was actually shared in the heart team. While surgically it is possible, patients has declined coronary artery bypass surgery. So we are now left with a percutaneous option here for this patient. So if you look at the angiogram of this patient, you can clearly see that he has got osteo left anterior descending artery as well as osteo circumflex artery, which appears to be highly calcified. Indeed, if you look at the proximal and the mid-LAD segment, there's also a very, very diffuse 90% calcific stenosis. At the same time, there's also a very distal tubular 90% stenosis here. So I'll be very curious to know what the panelists think, and how would you approach this patient from a percutaneous standpoint?
Hi, so this is the coronary angiography. Just to recap again, can we play back the last slide again? Just to recap again, on intravascular ultrasound, the left main actually measured 6 millimeter in terms of diameter. So we are looking at an osteo left anterior descending artery stenosis as well as the circumflex lesions here. So perhaps if we can go to the last frame of the video, I would like now to ask Teguh Santoso from Indonesia, and leaving that frame of that last video shots on, to tell me what will be your strategy for these patients in the light of EBC main and DK crush 5 that we just heard. Teguh.
Yes, I've seen the IVUS run from LED to left main, and it seems that the patient has long calcified lesions, the LED as well as part of the distal left main, and there is also calcium nodule, and the lesion length is more than 5 mm, so probably around 15 or more mm. I don't see any IVUS run from the circ to the left main, but I've heard from you that the circ is also calcified. So I think this case, looking at all these findings, this satisfies the criteria of complex distal left main bifurcation stenosis set by Professor Chen Xiaoliang in his many studies, including also Professor Junjie Zhang. Here, this is a complex distal left main bifurcation stenosis. I'm a great fan of DK crush study. So if I'm in your position, of course, I would incline to do DK crush to fix the problem with DK crush technique. And of course, we need to do a proper lesion preparations, doing rota, at least to the from the left to the LED. Probably question mark whether circ is important or not to be prepared. It all depends on the IVUS findings. But at least rota, and then after rota, I will do IVUS and see whether I have already debugged significantly all the lesions, the calcified lesions, and also induce a significant amount of cracks after balloon pre-dilatation. Then after I am sure that I already get a good platform for stent implantations, and of course Megatron is a very good stent to use. Of course, I may need to implant another stent in the circ, so circ, then left main LED, and I apply the DK crush study, DK crush technique.
So I heard you, so you're going to be doing intravascular imaging to guide you. You also will be doing some kind of lesions preparations, perhaps with some kind of rotational arthrectomy, or we can talk about what sort of device you want to use. And also, you have already decided that this is a complex distal left main, and you will go with a 2-stent strategy, and DK crush is your preferred strategy. I want to hear from Rosli from KL. So Rosli, can you tell me, would you do the same, or you have some other strategies in mind?
Well, thank you, Jim. So when I look at it, the ostal circ doesn't appear to be that significant. Perhaps in the proximal circumflex, but not ostal circumflex. I would have agreed with Teguh of good vessel preparation is key. And in this case, I would just like to do a provisional stenting strategy. I'll stent from the left main to the LED, and then decide if I need to do anything to the ostal circumflex. We don't have Megatron. So what we have is that we have 2 stents, the Onyx and also the Synergy that can go up to 5.75 easily. So in this case, I would use two stents for the LED, and the first stent, which is a smaller stent, and secondly, a stent that will go from the left main to a bigger stent that from the left main to overlap with the distal second stent, and then port it to as close as possible to a 5.75, or if I have a 6 mm balloon, a 6 mm balloon. So a provisional stent strategy for me, and if let's say I have to use a two-stent strategy, then the preference would be, in this case, quite likely a TAP procedure, which is simple and straightforward.
So Rosli, actually, maybe I didn't show you very well. There is actually a discrete stenosis around about 5 mm away from the ostium of the circumflex artery that probably will have to be treated as well. So are you comfortable leaving, say, a 5.7 fully expanded stent in the 6 mm left main artery?
Obviously, you like to have good position as much as possible. But at the same time, there are two things we have got to consider: the integrity of the stent. And secondly is that whether you really have a balloon that in your shell that can take up to about 6 mm. It's 5.0 and above, they tend to be a non-compliant balloon rather than a regular balloon. So as much as possible to get as good results, as good a position as much as possible. I think the flow is important in this case. There have been one or two small papers from Korea stating that you may not get as good a position, but as long as the flow is good, then the risk of stent thrombosis is going to be much lower.
Okay, so a little bit of malapposition might still be okay, but why not two-stent strategy, Rosli? The good thing is that this is a complex lesion that requires a upfront DK crush strategy. Do you assess these lesions to be complex, and what sort of criteria would you go for lesion complexity stratification?
I think yes, I agree that it is a complex lesion. But remember, in a patient that is heavily calcified, if you want to put in a two-stent strategy, it's a 5 mm from the real ostium, but really a two-stent strategy involving the left main does carry much higher risk. You need to get extremely good results as much as possible. Otherwise, the base rates will be much higher. That's my belief. And the EDC has somewhat allayed our fears about wanting to think about a two-stent strategy. Oh, sorry, about a provisional stent strategy.
Thank you, Rosli. I'd like now to go to China, Dr. Zhang Junjie, who is obviously an expert in DK crush because it comes from his centers, obviously. Junjie, how would you deal with a 6 mm vessel in China? I mean, are there stents in China that potentially may be able to treat these kind of lesions? And if not, what will be your strategy in a big artery like this?
Thank you very much for having me participate in this simple session. In China, the Megatron stent is still not available. For this particular case, according to the IVUS assessment, 6 mm left main. For me, in my practice, in China, now we have a domestic 5-hawk stent and also have integrity and synergy. So for me, all these stents, the big size stent can be over-dilated to a 5, maybe a 5 to 5.5. So for this case, when I select one stent crossover from LED to left main, for left main, I will use a big size balloon, something like a 5 balloon to do the post dilation. And also we can use a two balloon from LED to circumflex to the kissing balloon inflation to over dilate the proximal part. In terms of your question about the just as Rosli mentioned, there will be, I think, a little malapposition in the 6 mm left main. But according to the data, we can know for this scenario, there will not increase the risk of stent thrombosis. So after I try my best and also check the IVUS, if a stent is where expansion up to 5 mm, for me, I will accept the result. Thanks.
Very interesting. So you do share the same opinion as Rosli that mildly malapose stent in the left main is probably acceptable as long as you get 5 over millimeter in terms of length deployment. So Junjie, is DK crush your technique here? I mean,
Yeah, definitely. Considering it's a complex application, definitely a big crush for me.
Would you do any lesion preparations beforehand?
Yeah, considering from the angio it's a severe calcified, especially the distal LAD, I will use a local ablation for the lesion prepare.
Wow, thank you very much. Well, we heard from two different camps here. One DK crush, the other one a provisional approach here. So let's go on to see the next recording and just to see what I've done for this patient.
So the plan for me was to attempt the left circumflex artery stenosis first, and then try to cover the lesions as much as possible with precise positioning at the ostium of the circumflex artery using IVUS-guidance. So, and then this is followed by intervention to the LAD artery. My take just from the angiographic assessment is that this patient requires some kind of lesion preparations in the form of rotational atherectomy to increase the chance of a procedure. So this is what I'm going to do. I'm going to do IVUS-guided PCI of the circumflex, and then followed by the IVUS-guided PCI plus rotation of the LAD artery. Okay.
This is a three-stent strategy adopted for the circumflex. And after which, the IVUS couldn't go beyond that proximal left anterior descending artery stenosis. So, so I did a free wiring with a rotor wire.
There already.
So this is a 1.2 fiber.
Flora again. Flora, stop.
Procedure was a little bit challenging because patients struggling with me, and so I went all the way down to the distal LAD segment as well. Sorry, I think it's a 1.5 bar. So having stented the whole LAD, right at the proximal end, this is where I put the Megatron 3.5 by 20 millimeter.
The circumflex. Down. We'll see. Maybe on 3 first. So what I've done is that after precise positioning of the circumflex ostium, I opted to do a rotational atherectomy of the LAD artery. So there was a bit of challenge dealing with the wire, but I started off with a 1.25 millimeter burr, and this was then upsized to a 1.5 millimeter burr. I tried to cover the distal LAD stenosis as well. As you can see that during the whole process, the distal LAD was quite challenging, but anyhow, we managed to put in a stent. So what I've done is a sequential stenting of the entire LAD artery, beginning from the distal part using a synergy of 2.25 millimeter stent, then overlapping with a 2.5, and then finally in the proximal part of the LAD extending into the distal left main artery, I use a Megatron 3.5 by 20 millimeter stent. So this is now the completion of the stenting procedure. I'm going to confirm it on the intravascular ultrasound, the results, and following which I will complete it with a kissing balloon of the LAD and the circumflex, and that should be the end of the procedure. Okay, now LAD.
So this is a two-step sequential
LAD.
kissing balloon inflation.
18. Down. Both nominal.
Remember, this is a T-stent technique here. Even crossing into the side branch was also a bit challenging.
Okay. Both 14, please. Down together. Down.
So this is a kissing balloon inflation.
Give me back the 6 balloon again.
So fortunate to have a NC emerge 6.0 by 8 millimeter balloon in the lab, so we could easily take it up to a 6.0.
Okay, up. Nominal. Okay, now.
6.0 can look really big. So this need to be a 6-7 French system here. This is the IVUS. Fairly well opposed here.
Now better already, isn't it? So this is the final angiogram shot after a kissing balloon and followed by a port with a 6.0 balloon in the left main. Angiographically, it looks pretty good. Intravascular ultrasounds also show well opposed stance. So you can really see how this Megatron stance can really be stretched from a 3.5 that was chosen, then it goes all the way to a 6.0 square millimeter, 6.0 millimeter balloon in the left main artery. So this is what Megatron is all about. It's meant for large vessel here with this great expansile characteristic that's really good for large vessel, particularly when we are dealing with a left main stent here. So this has been a very complicated case, but I think ultimately we achieve a pretty good results here with the reconstructed carina and left coronary artery stenosis. And all this were done with intravascular ultrasound guidance, and we only use a total of 80 cc of contrast in the entire procedure. So thank you very much for joining us in this demonstration, and I hope this has been an educational case for you. Thank you very much.
So Jack, this is a, obviously to me it's not a walk in the park, but maybe otherwise for you, but what would you have done in terms of strategy, and what do you think of the results here?
So, Hui-Chin, beautiful end result. I think this is definitely one way to go about it. So, just a few comments about what Hui-Chin did beautifully. Firstly, this is a guy with a creatinine of close to 300, CKD stage 4B, so you really have to cut down the contrast. This session focuses on imaging. Every time we want to do complex, calcified left main lesion, IVUS is key. So a good interpretation of the vessel size, length, the need for plug modification is all essential. In this case, I agree with the arthrectomy. What Hui-Chin didn't show, perhaps he did, was after the arthrectomy, a good scoring balloon or NC balloon to make sure that the lesion actually cracks. I'm a bit more nuanced about whether you need to get full expansion in a very heavily calcified vessel. Sometimes a plug modification is not where the calcium should be, so I would err on the side of caution. But I think that in this case, the Megatron stent in the left main location was actually perfect for its use. I think we could go from a 3.5 up to comfortably we saw in a 6.0 very well, and it shows no signs that he had issues. At the left main bifurcation, I still don't know what I would have done if I had done the case. I maybe tend to favor what Rosli said and just try to keep it provisional and as simple as possible. Not as skillful as Hui-Chin, I'm afraid. So back to you, Hui-Chin.
I understand that there's a questions coming from the audience, so can you share with us?
Yes, I think the question came from Dr. Frankie Tam from Hong Kong, because he said that he noticed the Megatron has the extra link. So his concern was there any difficulty in rewiring into the side branch, and any difficulty in doing the final kissing in your case?
There was some challenge going into the circumflex, but I'm not sure whether it is from the link itself. But certainly this is a stent that is built for strength, so it needed the connectors, more connectors here to enhance in strength. And so when it's designed for a big vessel, it's unlikely that you're going to deliver it very far and down the coronary vasculature. So it's really meant for proximal vessels and so forth. So I think there will be some compromise on deliverability with this additional link. But I think in the end, it is purposely built for large vessel, osteo lesions, fibrotic, calcified lesions, where you need the maximum radial strength to achieve the best results. Tagu, so I've got to learn from you as well. Tagu, what do you think, and any comment on the procedure?
Yeah, I think you fixed the problem very, very nicely. I'm very proud of you. And just several pointers. If we have to implant a stent from left main to the LED, and there is a big discrepancy between the size of left main and the LED. And then after that, we have to negotiate the stand and to enter the circ with the guide, to introduce the guide wire to across the stand struts to the circ. Very important is that we need to do pot first in the left main, because otherwise our wire will go abdominal, and that is in between the stand struts and the vessel wall. So we need to do pot and then introduce our wire. For decay crash, for example, in the proximal struts, stand struts, then we do kissing balloon dilatation, and after that we do repot. So this is very important. And the other thing is that if we have Megatron and we don't have the problem of, for example, peeling of polymer or stand fracture, because we can expand the stand up until 6 French. However, if we overdilate the regular stand, we have a potential problem of not only stand fractures or peeling of breakage of polymer, but also the cell can be so enlarged so that the middle part of the cell will not be get enough drugs. So this may induce restenosis.
So Teguh, did you think that it is much easier to do this T-stand strategy than your DK crush? I mean, DK crush is going to entail 7 steps here. So by just doing a T-stand thing, I obviously simplify the entire procedure. What's your take? So my take here is that you don't have to do DK crush all the time.
I don't understand you.
So did you think that this 2-stand strategy of mine is much easier than the DK crush that you're proposing?
Yes, I think it's relatively easier, but in my opinion, for complex lesion like this, I don't normally incline to do the simplest way to fix the problem. Because if you look at the data from DK Crash 5, for example, or definition trial, we know that even with the complex technique like DK Crash, we can get better result as compared even to professional standing strategy, which is the simplest technique. So not necessarily that complex technique is worse as compared to easier technique. I think Junjie can help me.
I want to ask Zhang Junjie now. And Junjie, did you think that it is the 2-stand technique itself, or is it the results of the PCI that you obtain with whatever techniques that really is the ultimate determinant of the outcomes of a left main PCI? I mean, I can do a T-stand here, I get good results based on all the criteria and so forth. Do I not expect the same outcomes as a DK crush?
Yeah, very important questions. Regarding its complex left main bifurcation lesions, according to the definition and the DK criteria trial, I think 2-stand technique should be superior to provisional standing. And I think most important things for complex procedure, I think we should pursue the excellent result. So at this time, I think IVUS-guided PCI procedure, especially 2-stand technique, I think will maybe achieve even better result. So far, according to our experience, because DK crush guided with IVUS guidance will achieve, I think, the excellent result.
So you have taught us about how to use intravascular imaging to optimize results. We've always been talking about using IVUS, but yet how to use IVUS to achieve an optimal PCI is something that we actually learned a lot from you from the ultimate trial. So maybe you can recap to us what is defined as an optimal PCI results on IVUS.
Yeah, according to the ultimate trial, we reported the 3 years follow-up data, and still show we should not only use IVUS, we should achieve the optimal result according to the IVUS. So the criteria for IVUS-guided PCI is the following three. The first is the minimum stent area should at least 5 millimeter, or stent expansion at least 90%. Secondly is relative plug burden at either proximal or distal to the stent edge should less than 50%. And the third one is there is no stent edge dissection longer than 3 millimeter involved the median. All these three criteria achieved, we can define the optimal IVUS-guided PCI. As this scenario, the 3 years TVF only 4.4. That's the result of the ultimate trial. And also recently, the colleague from Korea and our team merged the data, patient-level data of ultimate and the XPR trial. And we also get a very important result at the 3-year follow-up. IVUS-guided PCI can achieve the lower risk, lower rate of cardio death. That's very important.
That's why I cannot overstate the importance of using imaging in the right way. It is not just pulling out IVUS-guided, it is using it to optimize the result that ultimately matter. One of the issues here is this patient's renal impairment, Jack. One of the formula that I often use is this 2.7 multiplied by the EGFR, and that has been known to actually reduce the incidence of contrast-induced nephropathy if you want to attempt on somebody. So this gentleman has got about 29, so I multiply by 2.7 is around about 80. So I know that is the rough amount that I have to work on. How would you do a contrastless PCI as some people propose?
So I think it's not contrastless, but contrastless. So I think the most important is knowing your own capabilities. If you push too hard for contrast 0, you're going to end up with complication if you're not up for it. So I think the first priority in our mind is still safety. We do know you have a contrast max. And then there are other strategies to mitigate contrast-induced nephropathy, like the Poseidon trial show us. You can properly use a hemodynamic guided hydration, pre and post procedure. And of course, less contrast better. So I would say contrast less, not contrast 0, Hui-Chin. Thanks.
Certainly using intravascular imaging does help you to, prepare your strategy. You actually can prepare the lesions. You know exactly where's the landing zone and what you need to do before putting in the stent. So the imaging part is really the key in any sort of contrast-less PCI. So this is a gentleman obviously at high bleeding risk by our current definition. He's a chronic renal failure patient. He's an elderly. He's got a hemoglobin that's a little bit on the low side of normal. How long a DAPT will you give for this gentleman, given that he's a high bleeding risk in the context of a master depth? Is abbreviated DAPT appropriate for this gentleman?
So thanks very much for this very important question, Prof. I think if you look at the complexity of the case, I think you can regard this patient as having a high thrombotic risk as well, because you stented the left main to LAD, and there's a stent in the, all stents in the LAD as well as the left circumflex. So you have a patient with high thrombotic risk and high bleeding risk. And the important thing is the patient presented with an STEMI, so ACS presentation. So I think we have to decide what is the duration of DAPT. I think, of course, we know there is good data from the master depth, but equally there's also the data from stop depth to ACS, where they say 1 month depth is actually inferior compared to the standard DAPT. So for this patient, I probably put it on 6 months at least to a year if he can tolerate. That's my take on it. Despite his high bleeding risk baseline profile, Jack, would that be your would that be your strategy as well in terms of DAPT?
Yeah, thanks. I like Hui-Chin and Hihua's sense. If you look at the ARC criteria, he does only probably fulfill 1, which is an EGFR criteria. He's still 73 years old, and his HB is still more than 11. So I think his complexity of a PCI with near 2-stent bifurcation, long segment atherectomy, I would favor at least 3 months to 6 months of that before truncation. Thanks, Hui-Chin. So, Tagu, I'd like you to give your final comments as far as this patient's
management is concerned, and what do you think is the role of a Megatron here?
The role of?
Megatron stent. You know, this transformer.
I completely agree with you. I think you've chosen the best stent for this kind of anatomy. If I have access to this stent, of course, in the future, I will use this for probably most of my left main patients, considering all the good features of this stent. For example, not only deliverability, but also feasibility, radial strength, side branch access, and of course, the ability to expand the proximal part of the stent up until 6 mm. And I think this is probably the best stent for left main bifurcation stenosis that we quite often find in our day-to-day clinical practice.
Yeah, so actually the radial opacity to me is also an added advantage. So certainly in using it for a T-stent strategy, just to be able to see where the stent is at the ostium of the circumflex artery, does give me a lot of confidence in terms of the success of the technique. So Junjie, is DT crush the only stenting strategy that you will use now for the left main PCI? Would you think that T-stenting of this of mine here would be a lot simpler?
Almost, I think for complex left main bifurcation, I will use DK crush. But some scenario like something like T-shape, maybe I think I will also use T-stenting. But I will check with IVUS to avoid the miscover the ostimal circumflex, which will increase the risk of stenosis of the circumflex.
Thank you very much. On that note, I think it's important that we remember and take home some messages. So what will be a good take-home messages from this particular symposium? I think complex left main PCI bifurcations do require two-stent strategy performed in a meticulous manner. To me, it is not just the technique itself, but the fact that you can get the good results based on intravascular imaging, that is critical. And also, to me, it's not the two-stent strategy, which type that matters. It is always going to be morphology directed. It all depends on the bifurcation lesion. And I just don't think that one size does fit all for all left main bifurcations lesion. Intravascular imaging is definitely useful, particularly in patients with chronic renal impairment, where you are trying to minimize the volume of contrast use, and that will certainly help in terms of enhancing the safety and the efficacy of the entire procedure. And I'm glad that there is this dedicated stent that is designed and purpose-built for a large vessel like Megatron, and it just makes our life a lot easier. And now I have something that I can fall back on when I look at another lesion or vessel of a similar size and complexity. So with that, I'd like to thank my fellow discussants, both in the studio as well as in the remote locations, wherever you are, and also the audience for participating in this symposium. Thank you very much, and stay on because we do have another exciting sessions on mechanical circulatory support symposium coming up.